So welcome everyone to the first Virtual Molecular Tumour Board. My name is Juyun, and before I get on to my slides, I'll turn it over to my colleague Kaiser.
Hi everyone, my name is Kester Nanin. I am the program manager and the education lead for the Ontario Molecular Pathology Research Network. OMPRN is happy to support this Virtual Molecular Tumour Board as it aligns with our educational mandate, and it also happens to complement our other educational offerings, which include our patient education initiative and the Molecular Pathology Virtual Education Series that we're running in collaboration with the CAP-ACP and the Alberta Molecular Pathology Program. The support from OMPRN for this series facilitates meeting logistics, including registration and recording of each of these sessions. We also help to secure the accreditation for the series for continued professional development credits. The meetings themselves will be recorded and will be made available to those who have registered for the series. The Virtual Molecular Tumour Board is also accredited for continuing professional development credits, and certificates will be sent out at the end of the calendar year. To ensure that you receive your certificate, you must register for each of the monthly sessions, and the registration list as well as the Zoom participant log will both be used by the accreditors as a record of your participation. So make sure that your name when you register and when you log in are consistent with what you'd like to see on your certificate. As part of the accreditation, you'll also be receiving a brief survey about the presentation, so please be sure to complete that when it reaches you or your inbox. So that's all I wanted to say for now at the beginning, and I'll turn it back over to Jiyun for the presentation.
All right, thank you very much. And again, welcome, and especially to those who are joining us in early hours from all the way from Alberta and some from BC. So just note that we will be adjusting the hour of this session for subsequent sessions, so that it's easier for the colleagues in the West to join us. But thank you all for being here. So this was organized as a team effort between myself and shout outs to other members of the team, the Rashmi, Shamini, and working closely with Harriet, Kester, and Ian King. And we all come from actually very interestingly different backgrounds. So I myself am a anatomical pathologist by trained, and I did my molecular fellowship at UPenn, which was followed by a Surg Path fellowship in gynepathology at Brigham. And we also have members, Rashmi, whose background is in both molecular pathology and heme path, and of course Shamini, who's ABMGG and CCMG geneticist. So so some of the motivation for this session is to really create a platform for us to discuss, have these interactive sessions. So, you know, there's sort of multi goals for this platform, one of which is education, and part of it can be dedicated to somewhat more didactic session where someone's giving a lecture, but not too long, 20 to 30 minutes, focus on some form of molecular testing that's relevant for labs, for clinical labs, hopefully. But this is not another didactic session platform. We are really hoping to have discussion of cases, and that's where so the large motivation for this comes from. And this can be cases that are interesting for whatever reason, whether it's technical reason, biological reason, clinical reason. And we encourage people in the circle of care to also join us for the discussion of these cases. So that can include your med-onc colleagues, your rad-onc colleagues, your surg-onc colleagues, as well as people from the various labs. The other part that I was also hoping to also include is discussion table, where the labs can discuss various challenges that we face, whether it's validation, workflow, and so on and so forth. So the first part, the education round, you know, it could be education seminar about the specific lab tests. Your validation findings could also be discussed here. Your research data that's relevant can be also discussed here. Or it could be even just a journal club presentation that you think is of interest to this community. Sample topics could focus on things like clinical pathomolecular correlation that are particularly interesting, or some aspects of the workflow. And in this, I would include both the wet and the dry bench. And bioinformatics for some people is a little bit like a rather foreign topic to a lot of people. So I encourage people who have background in bioinformatics to come and give us presentations that you think would be interesting for us. We talk a lot about variants, and there have been some interesting papers on variant tiering, annotation, classification, and such. So these are all relevant papers that could be discussed, as well as your own practice. If you deviate from the probably more common AMP tiering practice, what system do you use? How do you adapt the different guidelines and such and so forth? I think another topic that's kind of particularly interesting to me is discussion of metadata. So looking at things like tumor mutation burden, mutation signature, and things like that are good topics for this forum as well. Really hoping to get a lot of cases as we go forward, and really encourage everyone to email me, contact me with cases that you'd like to present. And when you do present, I encourage everyone to share the full gene variant information if you're going to talk about variants. So that's gene transcript, C dot, P dot, as well as VAF if that information is available. In knowing that there are definitely heterogeneity in what transcript that we use amongst the different labs, even just in Ontario. So by sharing full information, then we know exactly what variant we're looking at. So if there's a discussion as to how different labs may have tiered it, that's easier. That discussion is facilitated. If you're able to also share why you tiered it as tier 1, tier 2, tier 3, or 4, let us know, and that can also be a very interesting discussion as well. And if there's particularly insightful papers that you've used to really drive the tiering, that we want to hear about it as well. This is not something that's the only focus on these NGS or various kind of discussions, but as you will see later, we can also discuss PCR studies, methylation studies, and so on and so forth. For oncologists, medical oncologists, if you have sent something out for, let's say, foundation testing, if there's something that you don't understand or you'd like to hear us from other labs about the findings for that particular case, we're happy to discuss those cases as well. Please note, however, that this forum, the people in the audience are not considered part of quote unquote circle of care. So we do have to restrict some information that are shared in presenting the cases, but we can share things like age, pathological diagnosis and data, including immunostain results, as well as any kind of the primary molecular or orthogonal molecular data, and some of the technical data that's relevant for the lab findings as well. So these will not be considered PHIs, but anything more granular, please be careful. But as we're not considered the circle of care. Part 3, discussion table. It's kind of what I like to sort of think of our opportunity to sort of geek out. So talking about workflow challenges, validation challenges, and sort of all the granular things that are kind of may not be seemingly relevant to a lot of other people, but certainly relevant to us. So one thing I kind of, as an example here, for example, is HE19 versus HE38. It's for those of you who are not familiar with those terms, these are the different versions of the reference genome, and has a huge impact on lab practice, but something that we don't really get to talk about all that often in a lot of other settings. except for very molecular specific meetings. But if but you know, in terms of tools that are available, it's, you know, HG19 and 38 are very different, and so a lot of bioinformatic vendors may not have support for HG38, for example. So all these things that are technical but very interesting to lab practices. I encourage these topics to be discussed. And one thing that I think would be very interesting is the use of polls and trying to get a sense of what other labs are doing in our country, and trying to see how we can help one another. So with that, I encourage you to contact me with questions, presentation ideas, and if you have cases, please let us know. Of course, if you have presentation ideas, you can let me know well in advance. Cases, I understand that things may come a little later and sort of closer to the dates, but you do have to let us know in advance, because as a speaker in this forum with accreditation purposes, you do have to fill out a conflict of interest form and do let us know about any kind of conflicts. Are there any questions at this point? So I'm just gonna bring this up here. Yeah. So if not, let's just launch into the cases. So I'll be presenting two cases, and the way I've sort of formatted this discussion is a little bit like a mishmash of, you know, the topics 1 to 3. So there's a little bit of not just the cases themselves, but also sort of talking about some of the technical things and whatnot. And so hopefully this will be interesting to all members of the audience here. So case 1, 73-year-old female presents with postmenopausal bleeding. It's a very common presentation for someone with endometrial lesions. Underwent resection of what they thought was looked like polypoid lesion in the endometrial / cervical. So it could well be lower uterine segment, which is something that could be interesting in some of the cases of suspected Lynch, where the LUS, the lower uterine segment, is more often the region within the uterus that's more commonly affected. Well, that's neither here or there. The histological diagnosis was a 5 grade 1 endometrial carcinoma. But the interesting part, I think, is this, so that the H&E shows a combination of these somewhat better separated glands, as well as things that kind of fuse. And it's probably better seen actually on some of the immunostain, where you can see some of the rather discrete glands right here. So this is better in fitting with precursor or endometrial intraepithelial neoplasia, whereas in this area, it's actually sort of the architecture is a little more complex, so it's better fitting with carcinoma. But what you see here is that, you know, comparing MLH1, PMS2, there's a geographical divide in the regions that are showing clear expression of PMS2 and loss of PMS in the lesion. And there's some still maybe retaining expression, or at least some immunoreactivity there, but certainly aberrant in the sense that there's a drastic reduction compared to this region here. MSH6 as well as MSH2 were both intact, as you can see here. So people have, and you may see some different words used in pathology reports, but this is something I call a subclonal loss pattern of MLH1 and PMS2. So first question, in assessing MLH1 promoter status, my lab performs macro dissection. So that's when pathologist marks and the lab scrapes that area corresponding in the unstained sections. Manual micro dissections, that's dissection under microscope in the lab. Laser capture micro dissection, or none of the above. So we're doing there's very low tech, so just put in your answers in the chat, please. I'll just give a few minutes for some answers. Okay. I think, that's kind of reflective of what I was kind of expecting. Most labs use macro dissection, which is common clinical practice. Dr. Stein, you do number 2. Can you comment on that?
Just because everybody else was choosing number 1. And it seems to me that having it with a dissecting microscope, you could identify areas that maybe look a little bit different and deserve a separate assessment.
Yeah, thank you very much.
No good reason except that I didn't want everybody to be completely unanimous.
Fair enough. So I have done, manual micro dissection in the clinical lab, and I use it for when I was looking at molar pregnancies. So when I was trying to minimize maternal tissue contamination, so I would take that thing, and either myself or the technologist, would actually dissect things under the microscope, and with those identity testing, maternal contamination can have huge impact on some of those peaks. So that doesn't make it easier. I'm kind of glad that no one chose 3, because I see this in the CAP surveys all the time, and I kind of always wondered to myself, who has the time to do this in the clinical lab? And I have a feeling that no one really does. I've done this for research, and it's very important for some settings and certainly some research questions, but it takes me hours to cut anything out. So I'm always curious, who has the kind of resources to devote to that. But I think it's macro dissection is certainly the most common practice. Okay, so this patient underwent subsequent resection, hysterectomy, and you can see that some of the regions here that just in case you can see that, just gonna close it. In an area which is clearly endometrioid, but interestingly had an area where it's kind of a little bit more spindle kind of morphology to it. But the further staining workup show that this is also actually just still carcinoma, but just has an unusual morphology to it. But it is something that you do want to think about in the endometrium, where the neoplasia as well as the physiologic endometrium are very, very dynamic in their morphology. And certainly when you think about endometrium and you have something that's spindle, one of the things that you want to think about are things like, carcinoma sarcoma, or the carcinoma undergo sarcomatous differentiation. But this was not the case here. But I've certainly seen very interesting morphology, let's just say, in cases with MR deficiency. And this was one particular case where both areas showed the MLH1 loss. So it was, I did not see subclonal pattern, at least in this particular block. At least in the gynae world, and certainly when we're talking about endometrial carcinoma, we talk about subclonal pattern or subzonal pattern of MLH1 loss. Usually if it's loss, it's usually MLH1, and kind of touch on that a little later. But certainly this pattern of geographical loss where you have intact areas and then the lost areas, you can certainly see that. And I gotta say, this paper was titled "Unusual Pattern of Histochemistry" or something to that effect. But I gotta say, I see this not infrequently. So in their study, this was back in 2016, most of the cases had subclonal loss of MLH1, and there was one case with MSH6 loss, with some variants that I don't quite know what to make of, to be honest, in terms of sort of this. So they did have a in-frame deletion MLH1, or sorry, in-frame deletion MH6, and a splice site variant MLH1 did have loss of MLH1 as well, and subclonal loss of MSH6. Not sure if that really lines up, but I think what's at least sort of more pertinent to the case that I'm presenting is in number of cases with the subclonal loss of MLH1 showed methylation of MLH1 promoter methylation in both the areas that were deficient in MLH1 as well as intact MLH1 methylation. But where they differed was when they looked at MSI testing by PCR, there were some differences in that the intact regions tend to work for the most part as MSS, where the other cases had a low for the or most part and high MSI. I don't usually sign up GI, gastric so colorectal carcinoma is not something I usually look at, but certainly this is also seen in the GI world, and this is actually a paper from the EHN group when Dr. Ranjan Pichetti was still there, but can be seen in there as well, and so certainly the geographical loss of MLH1 and PMS2, but also this case also had heterogeneous expression of MLH1 and PMS2. Now, the difficulty though with this kind of pattern is that, I see this all the time in cases that are poorly fixed. And so if I just see something like that where the expression levels goes in and out, I would have a hard time marking that as being aberrant. The same with PMS2 here. So that can pose a certain difficulty, whereas in something with more geographical like this, that's easier to interpret as being subclonal. The other thing to note is that this is just a normal intestinal mucosa, and the expression level of MR proteins does depend on cell cycle phase. So here we have in the crypts the very strong expression, and it peters out as the cells mature. And this is something that we have known to correlate with Ki67 expression level, which is expressed in most of the cell cycles that are actively cycling. A little bit of loss there, and not expressed in G0. So if it's Ki67 positive, you do, for the most part, expect that cell to have at least a good subset of those cells to have expression of MR proteins. So we use that in pathology quite a bit. Here's another marker, phosphohistone 3, that we use in some of the labs here, but not all the search path labs have that. So that's more towards the G2M phase of the cell cycles. So here's a case. This is another case where I have sort of nice junction between the again, there's a precursor EIN and sort of adjacent carcinoma. And here's a case that had MLH1 PMS loss in both the precursor and carcinoma regions. But going back to the poll questions, when you think about concordance, concordance between the precursor and carcinoma is only about half in the walk-in study, and usually if it's lost in the precursor, it's lost in the carcinoma, but that's not always the opposite case. And I gotta say, when I mark my areas for MLH1, I do sort of try to look at the immunostains and mark it with respect to that, but I actually don't know how many people look at immunostains and mark it with respect to that. But it's potentially a cause of false negative. Another poll question. My lab performs MLPA, RT-PCR or RT-PCR with bisulfite conversion, restriction digest, methylome profiling, others. Okay, so it looks like everyone who answered performs MLPA, which is very interesting. I thought at least some labs would be performing, MSPCR with bisulfite conversion, but it looks like MLPA is a very popular assay. It's certainly very robust. My lab's actually validating this assay where we're using restriction digest, and so we'll talk a little bit about that later. But looks like MLPA is very popular. another consideration to think about with respect to MLH1 from our methylation is regions. So, some assays are very region specific in the sense, and very narrow in terms of regions that are assayed, but we can sort of arbitrarily divide MLH1 promoter into 4 different regions with different number of CpG sites. But certainly a lot of CpG sites, certainly in region A, just don't have any correlation with MLH1 expression status. But they're the ones that better correlated were the regions in C, where you had sort of differential methylation, certainly were more commonly seen in cases with silencing of MLH1, and D, but to a lesser extent compared to C. So the assay that we're validating in my lab right now is a PCR-based kit combined with methylation specific restriction digest, where the non-methylated cases will see differential PCR patterns compared to methylated regions, and we're doing separate reactions for region C and D. And so this is just looking at a reference control where everything is methylated in this control, and can see good linearity with respect to both the regions C and D with some of this reference specimen. But that's a very arbitrary specimen, and in the sense that essentially it's kind of everything's kind of arbitrarily methylated, but good to see. So I think I kind of have an idea as to what you're gonna say, given that most people use MLPA. But next question: my lab assesses region C, D, C and D, or A to D, or none of the above combination. If you're using MLPA, you're probably gonna be looking at regions A to D. So let me just flip back to here that these are the different sites, and I think if I recall my details correctly, if you're using MLPA using the MRC Holland assay, you're probably looking at some snippets of A, B, C, D.
Julian, yeah, it does. The MRC Holland kit looks at all 4.
Yeah, thanks, Ian.
Yeah, I only know that because, like you say, A is discordant sometimes.
Yeah.
Chasing down samples where A was completely different from everything else, you go to the packet insert and then find out that they targeted a region that doesn't correlate to expression. It was kind of frustrating, to be honest. So yeah, that's the only reason I know that.
So Ian, maybe I can just put you on a spot for a bit if you don't mind, but when is A ever useful?
It's often concordant. It's not discordant very often. And I guess maybe maybe it's, it kind of adds to your confidence if the other ones are off. But you get cases where it's completely discordant with the other 3 figures. So it's kind of I would say probably shouldn't be there, but there's research uses for this kit too. So I'm sure there's people who want it.
So what do you do when there's an isolated A hypermethylation?
I ignore it. Because it does happen not infrequently.
Yeah, and I think everyone would too, right? And I think data are support your practice.
Yeah, I think D is actually the most correlated to expression, if memory serves. So I think maybe there's a case of privileging D somehow, but I don't know.
Really? Okay. My understanding was C, but C
this also doesn't help that they're out of order on the MRC Holland kit. A is number 3rd, so it's I always thought of it as number 3, and then reading the product insert, you realize that no, that's actually the farthest away, even though it's they order it by probe length, so it's kind of confusing.
There's nitty-gritty things that sometimes just kind of Anyway, good assay though. Good assay. Thank you.
Clearly, everybody thinks so. Yeah.
Yep. All right, so that's interesting. So, kind of getting to this. So generally speaking, I think a lot of labs report as detected or non-detected, but I'm just wondering, I'm curious whether people actually use this thing as quote unquote partially methylated and whether they report percent methylation. I think people are starting to feel shy or something, but I think one is probably the most common practice, but I have seen some labs report out percent methylated. Now, so if I were to switch my hats and as a surgical pathologist, I'm not sure I really know what to do with this value, especially if it comes from an outside lab. Now, one of the things that kind of surprised me, to be honest, when I was doing the product insert for the Entrogen kit, is that they have this actually correct category where things can be reported out as partially methylated, and of course it's a quantitative assay, so I can report out the percent methylated. But if something is quote unquote partially methylated, I'm not aware of any clinical significance to that. When we talked about when we talk about MGMT methylation, certainly the weakly methylated, I guess some people call it partially methylated, is something that is probably a little different than fully methylated, and it is kind of helpful knowing that. But for MLH1, I'm guessing no one here reports out as partially methylated. I'm not sure if that means anything. So I think one is probably the most common practice, and certainly the ones that I'm used to as the receiving end, but as well as in terms of sort of knowing what people do in other labs, what they do as well. So I think this may be the last poll question, but please participate. This makes it more fun. Anyway, so going back to this case though, one of the reasons why I brought this case to this forum is that, so I went back, so I looked at different regions within the hysterectomy, which is the top, as well as the biopsy. So going back to hysterectomy, I found this little region where there was histologically normal endometrium. So this is a little bit of bacillus, and then we have the neoplastic endometrium on top of it. And of course, here we have that area with the spindle morphology where it's just full out carcinoma. And then so the B and C were areas going back to the biopsy where I saw intact expression of MLH1, and C where it was deficient in MLH1. So when and then I performed the Entrogen assay, and interestingly, this was what I saw. So in area A, where it's normal, it's kind of what the blank limiter blank kind of is. Certainly with non-lesional, you can get some signal, but very low. In the precursor region where I saw proficient expression of MLH1, again, it's pretty close to the normal bacillus signal. And in the precursor with deficient MLH1 PMS2, I saw very high signals in both region C and D, and of course in carcinoma, as similar story as well. And this is not just for their tumor cellularity, and so really around kind of 100%. So this is very interesting because there aren't too many cases that I know of where you see discordance, at least with respect to MLH1 methylation status, in sort of this subclonal kind of manner. And as you saw in the earlier paper that I showed you, they were, for the most part, with respect to MLH1 promoter methylation, at least, they were concordant. So this is one case where you see discordant result, at least in the precursor. So interesting case in the sense that it's a endometrial carcinoma, 5 grade 1 with subclonal MLH1 PMS2 expression pattern, at least in some of the areas with the EIN and subclonal MLH1 promoter methylation. So before I get to the next case, any questions, comments?
Gene, I think this is super interesting. And just like with pretty much everything else, studies on clonality and how that affects, you know, the answers you get out of molecular assays is just completely understudied. And, you know, we do all these things on, you know, large pieces of the tumor and just trust that the clonality effects will sort themselves out and see, you know, so maybe I can comment later after your second case, but looking at the clonality, it seems like, you know, that's super interesting and super important. I wish people did more of that.
Yeah. One day we'll be doing single cell sequencing again. Then we have to sort this all out.
You have to talk to Lincoln about that.
Oh, fun times ahead, I'm sure. All right. Any other questions, comments? Okay. 20 minutes left, I'm told. So I'll speed up a little bit. Case 2, 48-year-old biopsy-proven endometrial adenocarcinoma. Underwent resection, total abdominal hysterectomy plus bilateral salping oophorectomy. And this is what I saw. So again, the kind of the heterogeneous kind of pattern of MLH1 and PMS2. Sometimes though, you got to be careful in some of the hysterectomy specimens in the sense they often aren't fixed very well. And so kind of you know, you may sort of see almost like sort of luminal kind of necrosis in some of the sections, and they stain not well, not unsurprisingly, and had this carcinoma that I'll talk a little bit more about later. But interesting MSH2 and 6 patterns. So there's one gland here where you see stronger expression and so the base of the gland, and then sort of peters out some of the areas not seen with MLH1 and KMS2. So, I mean, certainly, if you go back to some of the papers that I showed you earlier, you can see this sort of subclonal pattern in cases with that MLH1 promoter methylation. But I think this, as a surgical pathologist, this is one of the kind of cases that I'd be a little more careful with. And you could even, you know, make the argument that you could potentially defer full interpretation of MR proteins until you have the molecular correlates, but highly suggestive of certainly a subclonal pattern. But when I look at the carcinoma, though, this is one of the things where I, you know, if I had a gynae colleague, I say, hink, you know, wink, wink, you know, hint, hint, and say, you know, a lot of immune cells, fairly significant cellologic ATPS. So you can see that some of the lesional cells, you know, that's probably is around 20 microns. That's maybe around 10 micron. And then here we have what, 40 microns. So high significant nuclear pleomorphism. And even though a lot of it is kind of gland forming, you know, the cellologic ATPI exceeds that of what I usually see in grade 1. So grade 2 is sort of how I end up grading it because of that. But also note that even though this is very highly atypical, there's a lot of cytoplasm, quite eosinophilic cytoplasm. And these are some of the histological correlates that we can see in this, not a separate entity, but this particular form of endometrial carcinoma. And so the NGS, so this is based on the in-house NGS panel that we're currently validating. But when I run this case, I see, of course, a poly mutation at a VAF of 16.1%, and also identified MSH2 and MSH6 variants, truncating the VAF around 10% as well. And no disease-associated TP53 variant was identified, and the immunohistochemistry was quote-unquote wild-type pattern. So why that's particularly interesting and important for us in the gynae world is that we use this very much for molecular subtyping of endometrial carcinoma, where we have, so this is the now fairly old TCGA study, but a very pivotal one in the sense that, looking at endometrioid and serous carcinoma, some are mixed of the two types, but this study focused on these two histotypes where we had we're combining different genomic features of the carcinoma. We were able to generate these four groups. So this is a decision tree. So something that is ultra mutated is something called was associated with polymutation. MS high, it's hypermutated, and of course the rest of it depended then on the copy number status, whether it's high, i.e. serous-like, or low, endometrioid. And this was highly significant in terms of progression-free survival, where the poly cases did not progress in this cohort. Later, subsequently, some of the studies show that some of the polycarcinomas can progress and recur, but certainly they are certainly associated still with much better prognosis. And the worst prognosis was seen with the cases with copy number high profile, and this was called serous-like. Now, this is based on a combination of platforms, including whole exome sequencing, and no one does that in clinical labs, at least certainly routinely. So some groups have come up with ways to approximate these TCGA subtypes, or come up with these molecular classifications. And one is the PORTEC approach, where rather than really true decision trees, it's actually sort of grouped into the four. And they had some guidance on how to deal with cases with multiple classifying alterations. But so you can see that some of this, I'm sorry about some of the blurry text, but a lot of it is actually dependent on immunohistochemistry. So 53 IHC, MMR IHC, and in all cases, they would sequence at least the EDM, the exonuclease domain, and if it was mutated, then it would be under a poly. If not, it's no specific molecular profile. The PROMIS algorithm actually flipped the nodes in the decision tree. So rather than having all the cases be sequenced for the poly EDM exonuclease domain mutation, they flipped the nodes so the MMR data come first. It's a lot cheaper to do this than rather than the sequence poly. So that's part of the rationale. But certainly this classification has undergone retrospective and prospective validation, and certainly the prognostic strength holds, but it is different than the true initial TCGA classification. So going back to the PORTEC mechanism, if you do have the exonuclease domain mutation, and if cases are deficient in MMR, just like in my case, the recommendation is treat it like poly, and it's still an open question whether we can truly hold back adjuvant therapy in some of these patients, but hopefully we'll have a better answer to that through some of these PORTEC trials. But this makes sense in the light of the fact that the TCGA subtyping is a decision tree. So the poly, if it's truly poly, does then supersede MMR. But the trouble is that, if you're just doing very pointed sequencing of the exonuclease domain, you don't have much in terms of genomic features. And so this case on my panel had a tumor mutation burden of 110.77 mutation per megabasis. This is on the drug enrichment pipeline. It's not a validated function, but certainly seeing something like this is very comforting in the sense that it's above 100, right? So that's usually kind of the threshold that a lot of people use to call something ultra mutated versus hypermutated. And it certainly does fit with poly. But if you look at the other variants though, these are interesting genes, but probably not significant in the context of poly mutation. But if you look at actually what nucleotide chains that there are, C to A, C to A, C to A. So this is something that's actually very much fitting with the poly driven carcinoma. Just to some of the background information, there are sort of two hotspots in poly, but there are other variants within the exonuclease domain that have been associated with pathogenicity. And probably the most commonly affected residue is the proline 286, which was, again, my case. And the proline to arginine is something that's been actually studied very well. And this is in the budding yeast, where the proline 286 actually corresponds to 301, and changing to a charged residue like arginine, I think that's right, then mucks up some of the structure of the exonuclease domain structure, and the resulting functionally is, you know, defective proofreading function of that particular poly enzyme. So now, if I go back to C-biopolar and just look at all the cases, redundant cases, and look at cases with putative driver poly mutations, there's actually significant overlap in terms of the cases that are poly mutated, as well as cases with MLH1 or any of these MMR gene mutations. And a lot of these are truncating mutations shown by these black squares here. But if it's truly poly mutated, at least in the gynae world, that is something that supersedes these MMR variants. Now, what's a little bit harder, at least in my mind, is that when I look at the colorectal TCGA study, you can get cases that are poly mutated, even in things like, you know, 411L, and have some detectable level MLH1 methylation. And in my mind, I think of MLH1 methylation and poly mutations as mutually exclusive events, and that probably is true in most cases. But I think this is where you need good pathoclinical molecular correlation, in the sense that you can have some cases that can have both. And I'll be curious to see, you know, whether these really are, you know, what drives what. And I'm not sure, but my gut feeling is that if it's poly mutated, and if it's truly poly and looking like poly in a lot of different things, including TMB, it probably is a true poly, and you may have some low level of methylation. But just the presence of these things alone should be looked at, you know, cautiously. Just another note, if you haven't thought about it, is that you can have syndromic associations. And I haven't come across any families myself, but if there's anyone in the audience who have experience, I'd be curious to hear about it. But certainly it's in the literature. But to some, this is a 40-year-old with aberrant MSH26 expression, subclonal loss pattern, but had a disassociated polyvariant and with high TMB that is ultra mutated. So and the molecular subtype is a poly mutated endometrial carcinoma, endometrioid. So I'll end my case presentations there and open up the floor for any further discussion. But if there's, again, any presentation topics, cases, please email me. And to you, audience, thank you. So maybe I'll ask them direct. Oh, Ian, okay.
Yeah, I was wondering, when you report IHC, I can't recall anybody ever noting, I don't read them very often, but noting clonal patterns and things like that. It's usually just reported, to my mind, as plus or minus. Is that something that you do?
So it could be buried in either the synoptic comment or the microscopic comment sometimes, or the full comment section in the path report. So those are three locations where you can see some of it. Some people may not make the distinction, but I make the distinction, and I certainly, you know, some of my colleagues in GynaePath do make that distinction. So, but when I go to a report in a synoptic report, though, This is something that's in line with CAP or CCO guidelines. I only have two criteria: it's present or absent. Intact or lost. So there's no like separate option for subclonal loss, but I often comment about it. Anyone who signed up GI in this audience? I'm wondering if anyone make that distinction. My feeling is it's less common in GI pathology. And I don't have a good sense of how often that is seen in GI. But it's in the literature, certainly.
Hi, Joyun.
Yes, sir.
Thanks for the great inaugural presentation today. I have a quick comment and a question. Full disclosure, I'm a heme path, so a lot of what you talked about was totally out of my bailiwick, but it was interesting no less. Something that you noted that I think is maybe worth unpackaging a bit is in regards to the laser capture microdissection.
Yeah.
And pointedly, your comment was, who has the time to do that? And I couldn't agree more. We have to be practical with how we approach these cases.
Yeah.
We do have the millisect, the Avino millisect here in Ottawa.
Oh, cool.
Brian does use it, I think, in a research capacity from time to time, perhaps on occasion with cases. But I'm not sure. I'm not sure it's a good approach to think, who has the time, right? That I think maybe we have to think about working smarter and maybe delegating tasks and integrating more automation so that we can use these approaches that to me make a lot of sense, right? And I think you would agree, if we could have an approach where we can enrich for tumor cells, particularly in scanty material, particularly when we're looking at molecular analyses that make a big difference, and we might not be able to distinguish tumor from non-tumor very well from a molecular analytic perspective.
Yeah.
Maybe do you think there are opportunities in the future to, like I said, make the time to use these, and as an example, I do mostly leukemias and lymphomas, and on occasion, we have, again, partial lymph node involvement or a GI biopsy where we're clearing a MALT, and a clonality assessment would be useful. But I know if I submit the whole sample, I'm going to get difficult to interpret results.
Yeah.
So incorporating something like that, where you have technologists or technicians even setting up the bench and performing this, is that dreaming in Technicolor, or do you think that that's actually something that we can envision in the foreseeable future?
It's something I thought a lot about, Phil. I don't know if it's foreseeable, but probably easier on your end in terms of heme path. So like we used to do a lot of chimerism assays when I was a fellow back in Philly, and we used magnetic bead sorting for a lot of chimerism assays. Not always, but so we could have used that capacity for sorting of different things. I was really surprised when I saw a OSCAP poster where they took FFPE blocks and they actually sorted those things in flow. I thought they would never work, but it seems like it is possible. So I feel like there are opportunities like that. And, we were kind of joking about single cell sequencing, coming to fruition at some point, but I think there are, like multiple lymphoma and that kind of thing is an area where you could have a clear indication, is where those things could be very useful. So I think kind of technology is kind of there in certain ways. It's very expensive though, but you know, with this 70/50 reimbursement, you know, who has not just the time, because you know every hour is, you know, what, $100, $200 of technologists, and then you know you're just really eating into that reimbursement, so it's really hard.
I couldn't agree more. It is hard, but I worry that we close the door on some potentially you know, good opportunities that might, you know, the cost might come down. You know, maybe 5 years ago, we're saying doing comprehensive genomic profiling is really hard. I don't think we can do it. It doesn't make a lot of sense, but actually it does make sense, and we can do it, and we can do it at a relatively, you know, relatively resource mindful way.
Yeah,
So
for sure.
I think as we move forward, maybe, you know, much like we do in the immunohistochemistry labs today, perhaps in 5 or 10 years, you know, some of these things would be routine training in MLT programs where they just learn to use a laser capture and it's actually quite automated. It's pretty neat. I'm not sure how many people have had an opportunity to see how the equipment works, but I know in the experiences that I've had with the Avenio platform, it's actually pretty neat, and it identifies pretty well where the tissue is, and does a remarkable job at actually enriching for tumor cells.
Yeah, I use the Thermo Fisher Arcturus platform, and you know, you don't often get to play with lasers, so that was kind of fun.
Yeah, exactly. Yeah.
Sorry, Andrea had a question. So I know we're at time, but just I want to give her an opportunity.
Thank you.
Yeah, thanks, Phil.
Yeah, thanks very much for your presentation. Really interesting. I think to Phil's point as well, I think we're certainly always very interested to have a look at these technologies, and we have looked at that Avenio. When we had it in the lab for a trial, the truth of the matter was that the throughput just doesn't work with the large volume of testing that we're doing. And so I agree. I think it would be wonderful, and you know, trying to automate is an excellent idea. I think the problem is that just the reality of it isn't quite there yet for a big, busy clinical lab in most cases.
Yeah.
So we would love to do it as well. It's not that we're you know, necessarily wanting to shut the door on it. It's just that practically speaking, we're just not there yet.
Yeah, for sure. You know, one of the projects I did as a resident was, you know, flow cytometry sorting, and then looking at PD-L1 expression level on you know, carcinoma cells, and you know, even that's trying to think about implementing something like that in the clinical world is very difficult. You know, not a lot of labs have that kind of sorting ability, and the tissues that we work with, frankly, aren't the best for that. So the things I was cutting out, you know, they were very small things, and they had to be cut out with laser, but you know, the downstream assay, that's a whole nother challenge altogether. So very good points. Thank you. So now we are at time, so I'm just going to turn the mic over to Kester for closing remarks. Thanks, everyone.